But we do want to go on and talk about novel approaches to treatment, to treating cancers, and particularly I want to talk about repurposed drugs. Drugs with a known safety profile, very often very safe. Drugs that have been used for decades. Drugs that have been used on, without exaggeration in the case of ivermectin, billions of people. Drugs which are very cheap. Drugs which can be manufactured literally by the ton, relatively cheaply because they're often fairly simple molecules. And drugs which may well be highly efficacious against the disease they were originally designed for or developed for or isolated for. But then out of lucky accidents, really, serendipitously, amenable to treating other conditions. And we have a lot of precedent for this. So aspirin, for example, from willow bark was initially used for treating fevers. Now we realise it reduces platelet viscosity and can prevent blood clotting and various other anti-inflammatory things. So this is not unique. This has happened quite a few times. I mean, there was a drug introduced for treating myocardial ischemia for angina, and it was later used for treating impotence as a surprise finding. So this isn't unusual. But what first arose your interest in repurposed drugs in the field of oncology?
I've started getting into repurposed drugs when I started my Substack in early 2023, and I really wanted to do a deep dive into early treatments for COVID-19. Yeah. Treatments such as ivermectin, hydroxychloroquine, and I wanted to know for myself, were these effective in COVID-19? Were they not? What was the science? What was the research telling us? Yeah. And of course, whenever you want to do a deep dive into a topic like that, you have to read the papers. And so I went and I read paper after paper, and I read dozens and dozens of paper, and I was particularly fascinated by ivermectin. Why this antiparasitic drug was the focus of so much attention in the United States, to the point where the FDA is telling people not to take it, and yet we have, as you mentioned, we have decades of prescriptions given of ivermectin. I think 4 billion doses at this point. Yeah. Excellent safety record around the world. Yeah. Unquestionable safety record established around the world. And yet, why was this a focus of such controversy and attention? And as I dove into that research into ivermectin, hydroxychloroquine, and so on, I discovered a large body of literature. Specifically with ivermectin and cancer, and ivermectin in the use of cancer, and I found that very odd and very unusual. And I of course, I was naturally curious. Well, why would ivermectin work in cancer? How does it work in cancer? And so, I did a PubMed search, and I think something like over 300 peer-reviewed papers come out, and in regards to ivermectin and cancer. Now, it's all preclinical research. And then you start looking at, well, where are the human trials? I want to see the human trials as well. But you see preclinical research where they're studying the cancer cell lines, or they're studying it in mice or rats. But this preclinical body of research on ivermectin and cancer is so impressive. It's not one or two papers, a group of researchers tinkering in the lab. These are dozens and dozens of paper, extensive research done, looking at the various mechanisms of how ivermectin might act in cancer, and what cancers ivermectin impacts. And it really seems to be a broad anti-cancer agent that can be used in a variety of cancers, anything from blood cancers to solid tumors as well. And it's just such a fascinating molecule, because when you look at the mechanisms of action, now this is an antiparasitic, a very successful antiparasitic, and yet it has different mechanisms of action in cancer. It targets cancer stem cells, for example, something that I find really fascinating, where it's able to attack these cancer stem cells that don't necessarily proliferate rapidly. But, these are cells that could cause problems in the future, that could cause metastases in the future, that could cause cancer recurrence in the future. And I believe that when you have standard chemotherapy will kill the rapidly dividing cells, just based on the nature of the rapid proliferation. But they will not kill slowly dividing cells often, and the chemotherapy may not kill cancer stem cells. And so you often hear chemo being referred to as palliative instead of curative. The intent is palliative to, they will tell you cannot cure stage 4 pancreatic cancer, for example. You cannot cure stage 4 ovarian cancer. We can buy you time with chemotherapy, which will kill most of the cancer and shrink a lot of the tumors and so on, but it will not kill the cancer stem cells, and it will not kill cancer cells that are resistant to that chemo, because cancer cells can develop a resistance to certain chemotherapy. They might have, these pumps that just pump the chemotherapy right out of the cell. And so in some cases, like ovarian cancer specifically, these tumors can develop a resistance to chemotherapy. That's why the oncologist has to change the chemo and go to the next agent and so on. Well, ivermectin can kill cancer stem cells that chemo can't. Ivermectin can also reverse what's called multi-drug resistance in cancer cells. And so it can actually sensitize cancer cells to chemotherapy. It's also a radiosensitizer. It can sensitize cancer cells to radiation therapy, for example, as well. Now, it has other actions. It can inhibit the tumor's ability to form new blood vessels, so it can inhibit angiogenesis. Ivermectin also inhibits certain enzymes called matrix metalloproteinases, which are enzymes that detach cancer cells from the tumor and allow it to metastasize and spread to other parts of the body through the bloodstream. And so ivermectin will actually inhibit those enzymes, so that it inhibits metastasis of the tumor, for example. So when you look at it, there's a dozen different mechanisms by which ivermectin acts on the molecular level on cancers. And so then you ask the question, where are the human trials? Yeah. Because that's what it ultimately comes down to. Yes, preclinical research is nice. We have hundreds of papers on ivermectin and cancer. Where are the human trials? And there aren't any. There are case reports. There's a case series on 3 patients with leukemia. I believe 2 of them were able to achieve some form of remission with ivermectin. And that's it. We don't have any randomized control trials. We don't have any large studies in humans. And then you find out, well, ivermectin's been off patent since the 1990s. I believe Merck held the patent. The patent expired in 96, I believe. And so it's a cheap drug that's off patent. And then you realize, okay, well, there's no money to be made in studying ivermectin in humans for cancer. And where there's no money to be made in oncology, tragically, the research just doesn't follow. Yeah. And so you see this focus, and this happens to a lot of repurposed drugs. And so, for example, you look at something like another antiparasitic, Membendazol or Membendazol. Now, this is a different family of antiparasitics than ivermectin. Membendazol was actually interestingly discovered by a terminal cancer patient from Oklahoma, Joe Tippins. And Joe Tippins had stage 4 small cell lung cancer, which is one of the most aggressive cancers known. And he had stage 4 small cell lung cancer diagnosis, terminal diagnosis, and I believe he was put on a trial of Keytruda at the time. And
is that a regular cancer drug?
It is a regular cancer drug, yes. And sort of what they call an immune checkpoint inhibitor. Yeah. And so he was put on Keytruda, and he tells the story later on that everybody on that trial died. He was the only one who survived. And he tells the story of how he had a friend who was a veterinarian who said, look, there's this parasitic drug, this dog dewormer called Membendazol. It's been accidentally found to have anti-cancer properties in mice. It's cheap. It's safe to take. Why don't you try it? And the story goes that, he tried this dog dewormer, dog medicine, I guess you could say, and he cured his stage 4 small cell lung cancer, which is completely unheard of. I think he was given a survival of less than 1%, sort of a 5-year survival of less than 1%. And he's still here to this day. 7 years later, he's cancer free. with a stage 4 small cell cancer diagnosis. And so at the time, he would actually go on news shows and talk about his experience of trying fenbendazole, which was not FDA approved for use in humans, and how it cured or he believed that it cured his stage 4 cancer. And then, I look into that research, that body of research. See, again, there's a ton of preclinical research on fenbendazole, and there's now been cases published by Stanford University Medical Center of 3 patients who cured their stage 4 cancer with fenbendazole. And the Stanford group looked into it, analyzed it, monitored these patients. These patients had all failed 3 or 4 lines of chemotherapy. They were terminal. They took fenbendazole, and they are now cancer-free. And the Stanford group published this. Now, the Stanford group itself, the researchers were not allowed to recommend that drug, fenbendazole, because it's not FDA approved. But they were at least, this is what I love about science, is that they saw something fascinating. They saw something that they thought other doctors and scientists should know about, and they published it. And they published this case series. You had actually talked about this. You had talked about this paper from 2021. This series of 3 people who had cured their cancer with fenbendazole. And so there is an FDA-approved version of fenbendazole called Membendazol. It's structurally almost identical. There's 1 atom difference between fenbendazole and Membendazol. Membendazole has been approved by the FDA as an antiparasitic drug for use in children and adults. And so it has an incredible safety profile, very safe to use. And Membendazole actually has a dozen clinical trials in which it's being looked at as a cancer agent, as a repurposed drug for cancer. And so I think because of its status as an FDA-approved drug, there was much more willingness in the oncology community to do trials with it. And so there are trials in adults looking at colon cancer and various prostate cancer, and there's also trials in children looking at brain cancers with Membendazole. And again, this is an antiparasitic drug that has a dozen mechanisms of action. One of the fascinating mechanisms of action in cancer is that it blocks glucose transporters on cancer cells. And so it sort of starves the cancer cell from being able to use glucose as a fuel source.
Specifically in cancer cells and not on normal cells.
Yeah, exactly.
Glucose transporting in cancer cells. That's amazing. So there must be something biochemically different about the glucose transporter in cancer cells compared to ordinary cells that it's able to specifically target.
Exactly. And what's fascinating about these repurposed drugs is they are very specific to cancer cells. They are able to somehow identify a cancer cell from a normal cell. And this has been studied in ivermectin as well, is ivermectin is actually able to identify lymphoma cells and act on them. And it's able to also identify normal cells, and it doesn't have that same effect on the normal cells.
It's what we call a magic bullet.
It is absolutely fascinating.
Yeah.
And I encourage anyone, look into the preclinical research. It is absolutely fascinating. And
the mechanisms that we're talking about here, that you're talking about, are based on known biochemical pathways. This is not something new. This is understood biochemistry, and these drugs interfere in a particular biochemical mechanism in a known biochemical way. This is not speculation. I mean, biochemistry is basically a hard science. I mean, medicine's a bit soft around the edges, but biochemistry is a hard science. It's bench chemistry, and you can't really argue with that. And the fact that it's got multiple mechanisms of action on multiple biochemical pathways, and that's true for ivermectin and the Membendazole-fenbendazole group. It's just absolutely incredible that these natural molecules seem to have these multiple modalities of action, and yet we're staring the gift horse in the mouth.
Exactly, and the research is very, very solid. The research on the mechanisms, the preclinical research, is very solid. This is not 1 or 2 papers. This has been, replicated. This is hundreds of papers for these antiparasitic drugs. So this is not, this is not a conspiracy theory. This is not fringe medicine.
This is hard science. It's as hard as it gets.
Absolutely. This is hard science. And I love, I'm always fascinated by preclinical research, because that is what we stand on. That is what the rest of medicine stands on, is the preclinical research. That's what we rely on as physicians.
And that's what gives us the plausible mechanisms of action, because if you can't give a plausible mechanism of action, well, you're not fulfilling an essential Bradford Hill criteria apart from anything else. But, if you can say, well, this is the way it's working, then that's what takes you into science away from mumbo jumbo. Because
Absolutely.
we've got existing science, and this pharmacodynamic effect, the way this drug is working, is dovetailing with what we already know, with multiple points of consistency with what is already known.
Exactly. And so I found myself in a situation where I was writing articles on Substack. I was writing articles about turbo cancer, potential mechanisms. We talked about this brand new pathophysiology of turbo cancers. And so I have a paper that I co-authored on the IgG4 shift. That could be one of the potential causes of turbo cancer, where we see someone who's had, let's say, multiple vaccines. They end up with an immune system shift, where they start producing different types of antibodies. And instead of producing IgG1 and 3, they start producing IgG4, which is an antibody that creates tolerance to something like the spike protein, but it also starts to tolerate cancer. And so I've been involved in some of this research in trying to figure out the mechanisms, but now I'm shifting towards treatment, and I'm shifting towards looking at, well, can we help patients with turbo cancer? How can we help them? Yeah. And certainly, I encourage everyone to pursue all the options in mainstream oncology, pursue all the options, whether it's chemotherapy, radiation therapy, immunotherapy. You have to pursue all those options. You have to have those discussions with your oncologist. But what else can you do? What if you're out of options? What other options are there? And I think this area of repurposed drugs, is something that we can try as clinicians, something that we can look into, advise patients on. And a lot of patients themselves are, they look at some of these repurposed drugs, and they start taking them. They start taking them themselves. So as I was writing about ivermectin and Membendazol and Membendazol in cancer, I had patients who actually started taking them, and then they would come back to me 6 months later and say, Dr. Makis, I read your articles and I took these on my own. There was no patient-doctor relationship or anything like that. They took them on their own, and they come back to me and they say, my cancers are shrinking. My oncologist is shocked. My oncologist told me I shouldn't be alive anymore, and yet I'm here. My cancer's stable. And so I kept getting story after story. And one or two stories you say, that's fantastic. I'm really happy for you. That's really terrific. But when you get a dozen or 24 stories like that, and that's what happened to me, is I started having so many patients coming back to me that I thought, there's something here where I could actually be helping patients with. I could be helping them with ivermectin. I could tell them about the potential side effects. I could guide them in dosing, for example. How do you dose these things, right? How do you find the appropriate dose for the appropriate condition? And so this is what I've been working on for the last 2 years. I did start a cancer clinic or sort of a cancer coaching or health coaching program with repurposed drugs, where I have cancer clients that come to me. We discuss the research, we look at the research, and we talk about repurposed drugs and what repurposed drugs they might use and want to try themselves. And so this is where I've been trying to go from just identifying the problem, saying, look, we've got this explosion of cancers, these turbo cancers, aggressive cancers, to actually helping patients and give them some options that they can use. And I've had some fascinating results. Patients, I've had, a number of stage 4 pancreatic cancer patients who've been now declared cancer-free, cholangiocarcinoma patients, ovarian cancer patients whose tumors are shrinking, even though they failed multiple lines of chemotherapy. And so,
these are cancers that were absolute death sentences. Exactly.
And another feature I wanted to just mention is that these repurposed drugs, when you look at the preclinical research, they have synergy with chemotherapy. They have synergy with immunotherapy and even radiation therapy in some cases. And
I was amazed at the radiotherapy one, that you can actually sensitize a drug to sensitize a cell to radio-induced cell death. Is just incredible. It's just brilliant. It's
fascinating, because when you look at some of these mechanisms, some of them are known and some of them are still unknown. And
yes,
and you see all these biochemical pathways that ivermectin acts on, and all these pathways where it changes the expression of certain proteins, and then suddenly you stimulate apoptosis of the cancer cell.
The cell just goes pop and dies.
Exactly, the programmed cell death, and so a lot of these pathways that ivermectin, membendazole act on are pro-apoptotic pathways, where you're bringing that cancer cell towards this programmed cell death, and you're also this idea of being able to remove drug resistance, a cancer cell that has developed drug resistance, to me is absolutely fascinating.
Yeah, how can you possibly reverse that? It's wonderful, but it's biochemistry well beyond my level of understanding, that's for sure. But,
it really is. It's pure biochemistry, and it's sometimes even I have a hard time understanding some of these pathways, but
I certainly do. Yeah.
But it really, the fact that it can affect expression of certain proteins and so
Amazing.
on, and it's incredible. Yeah. And so I think repurposed drugs. I think there's a big future in repurposed drugs, and I think repurposed drugs can give patients hope in situations that are very dire and in the past would be considered hopeless.
We're dealing with drugs that are very safe, very limited side effect profile, can nearly always be given with all the regular, what you might call standard cancer treatments.
Exactly.
And for people who've exhausted the standard cancer treatments, stage 4 pancreatic cancer, for example, why not? Why not try something that's not going to do you any harm? If you want to change the brand of whiskey that you drink in the last days of your life, then fine, try it. But something like this that is potentially can potentially improve the condition is just incredible. And I am optimistic again in the States that the right to try is going to be reintroduced, that people who are terminal can basically try whatever they want. And I agree with that. One of the things I always used to teach my students was in acute care, sometimes patients are going to die. And you always have to be in a position where you can walk into the relatives, you can tell them about this tragic death, and you can say, we tried absolutely everything at our disposal. Now, that's not always true, tragically, but we should always work to that situation. We tried absolutely everything we've got in 2025, nothing else we could have done. And so many people are dying now, and that cannot be said.
You're absolutely right.
I'm trying not to get cross now, but it's just not acceptable.
You're absolutely right in that the state of oncology in let's say in North America, for example, because I'm very familiar with state of oncology in North America, but I do have patients in the UK, in Ireland, in Australia. I have a global clientele, and so I do get insight into how oncology is practiced elsewhere. But the state of oncology in North America is that oncologists have these rigid guidelines and protocols that they follow. And
it's the same in the UK.
Yeah, and you have your first line chemo, second line chemo. Maybe you can throw in some immunotherapy in there, of course, radiation where appropriate, and so on. But they go step by step through these rigid guidelines, and they come to the end, and they tell the patient, "Sorry, there's nothing else we can do for you." But that's not true. That's not true. There's a whole body, there's a whole area of let's say repurposed drugs that you don't even know about, that you don't even tell your patient about, and we run into this situation. I have patients from Mayo Clinic, I have patients from Johns Hopkins, Memorial Sloan Kettering, MD Anderson, Dana-Farber, these leading cancer centers in the United States, and the patients come to me and they say, my doctor's saying, I'm out of options, or I'm running out of options, or they have nothing else to offer me. And it's not true. There is something that they can offer. But I always have this discussion with patients that, your oncologist probably is not allowed to offer you anything else or to suggest anything else, because there may be retaliation. There may, their licenses may be targeted, their jobs may be targeted. And the oncologists, it's true, the oncologists don't have the freedom to go off script, as I would say, or go outside of the guidelines.
True, but there's still big ethical questions there.
Oh, absolutely.
If I know something that might save someone's life and I don't tell them, that's got big ethical questions. But I want to enter a completely academic discussion now and look at doses of these drugs. If we start off with let's start off with ivermectin. What sort of doses might we be thinking about for maybe just give some examples of conditions that where you've got personal experience?
The starting dose that I look at with ivermectin is 1 milligram per kilogram per day.
Quite high.
And it is a little bit high. I always say this is about five times the dose that you would use for COVID-19 or a parasite infection, for example.
Yeah. Is this with what level of cancer is this with? Sorry.
This would be with most cancers, sort of intermediate to high grade cancers. Now, for low grade cancers, you could certainly start lower at half a milligram per kilogram per day. And so for a 60 kilogram person, typical starting dose would be about 60 milligrams of ivermectin. But for low grade, something like CLL, chronic lymphocytic leukemia, that's been simmering for many years, or maybe multiple myeloma, I start lower at half a milligram per kilogram. So that would be something like 30 milligrams. Right. Of ivermectin a day, and that's more in the range of a dose for a viral infection or a parasitic infection. Yep.
And is that 6 days a week?
That's 7 days a week.
7 days a week. For how many weeks?
So I suggest patients try ivermectin for cancer for 3 months, and I'll tell you the reasoning behind that. And then with a reassessment of some kind, looking at blood work, cancer markers, for example, or looking at follow-up imaging. The reason why I say 3 months is because, from my experience, I have seen a response to ivermectin on cancer markers as early as 3-4 weeks. So this is markers like prostate-specific antigen, PSA. We could see a drop in the PSA. We could see a drop in CEA or CA125. Or these other more specialized markers for breast cancer, for example.
These are basically chemicals given off by the cancer cells.
Exactly, and you can see those start to drop. Now they're not perfect tests, but they are surrogates for cancer activity, the level of cancer activity, or the level of tumor burden. How much active cancer is there where these cancer cells are producing these markers. You could see those markers start to drop, and you can actually start to see the activity of the tumors start to drop on a PET scan, a positron emission tomography scan, in about a month. But it takes a little bit longer to start seeing tumors physically shrink, lymph nodes shrink, primary tumors shrink. That takes about 2 to 3 months to start seeing that on imaging like MRI, PET CT, or CT. So you want to give it a good 3 months to see if you have a response. You could monitor it on the blood markers. Within a month or so, you could start seeing if there is a response, and then after 2-3 months, you could actually start seeing responses on imaging. And I'll tell you the most dramatic results that I've seen, and I get attacked from both sides. I get attacked from conventional oncology on this, and I get attacked from the sort of health freedom movement on this. But the best results I've seen in my patients are patients who are doing a combination of chemotherapy and ivermectin, and then combine it with either Membendazol or Membendazol as well. But when you do the combination treatment, there's a certain synergy, and that synergy is documented in preclinical research, where you get a lot more cancer cell killing with the combination than with any of those agents by themselves.
Well, it's consistent with what you were saying before about the sensitization of the malignant cells.
Exactly.
It does make sense, and there's precedent for this. Again, things like low dose naltrexone can sensitize people to.
Exactly.
Conventional chemotherapeutic agents. So those sorts of doses of ivermectin, we're talking about ivermectin on its own or with traditional cancer treatments.
That's right.
Yeah. So that's kind of almost like a monotherapy, isn't it, with ivermectin?
Well, in the sense, the fact that
monotherapy in terms of the pre-purpose therapy, you can be giving it with a range of other traditional oncologist prescribed drugs.
Yeah, and so when you are giving it with chemotherapy, it's sort of an adjunct in the sense that you're sort of adding it into you're adding it into your chemotherapy regimen, and patients will take the ivermectin throughout their chemotherapy regimen. I will tell you another fascinating story of a physician assistant I have in the United States who had already done 4 cycles of chemotherapy and started taking ivermectin, and I had suggested some dosing for him and so on. And the first thing he told me was, with my 5th cycle, I had no chemo symptoms. And he was playing golf the next day. And he said, usually the chemo will knock me out for 3 days. I can't do anything for 3 days. And, I started taking ivermectin, and then all my chemo symptoms were gone, and he was playing golf the next day, and he couldn't believe it. And the same thing happened the next cycle, and then the next cycle after that. And, and then his markers were dropping as well, and he was having a fantastic response.
So if you only took it to reduce the side effects, that would have been worthwhile.
Exactly. And so the ivermectin, in many cases, actually is able to reduce the side effects of the chemotherapy. And I think part of that may be because ivermectin does seem to have a very powerful anti-inflammatory component as well. And so I have other patients who don't have cancer, who I've guided with ivermectin. For example, patients with rheumatoid arthritis, whose symptoms improve dramatically. Patients with fibromyalgia, patients with Lyme disease, for example. I've seen dramatic improvements in these situations where patients been suffering with a chronic inflammatory condition for many, many years, and they get rapid relief with ivermectin within a few weeks of taking ivermectin. And this would be, again, a lower dose, about 0.5 milligram per kilogram for these inflammatory conditions. So I've seen dramatic response for inflammation. But like you said, even if it was just for improving the patient's quality of life during chemotherapy, it would be worthwhile because the side effect profile of ivermectin is so favorable.
Quite incredible. I wasn't aware of that, such a strong anti-inflammatory effect, I must say. Now the side effects with these sort of higher doses, are you seeing side effects? What side effects do you see?
I'm seeing some transient side effects. If you've never taken ivermectin before and you start at 1 milligram per kilogram per day, for a 60 kilogram person, that's 60 milligrams of ivermectin, you may have some transient visual symptoms. The visual symptoms have been described as seeing colors a little bit more vividly or seeing a little bit of stars. It's almost as if when you get up too quickly and you have that effect that you might faint. So there's been visual symptoms described. Now, these are temporary. They may last anywhere from a few minutes to a few hours, and they do go away with time. After 1 or 2 weeks of ivermectin use, the body seems to get used to it, and they go away.
Even maintaining the same dose of ivermectin.
Exactly.
Right.
And so there's reports. I mean, there's reports in the literature of ivermectin being used at 1 milligram per kilogram for up to a year with no side effects, and there's been no long-term effects reported with ivermectin use either. Now, if
no non-reversible neurological effects that you've ever come across.
None. Now, you could push the dose higher to 2 milligrams per kilograms per day, but you have to be cautious when you go to those higher doses. Now, I've had some successes going to the higher doses, especially with very aggressive cancer, pancreatic cancer, for example. I had a patient who cleared his pancreatic cancer with a few months of ivermectin, 2 milligrams per kilogram per day. But there you can start to get, especially in more elderly patients, you might get some confusion, you might get some instability on the feet. And so you have to be more careful going into the higher doses. Again, ivermectin has a half-life of 18 hours. So
Nice.
if you do run into some side effects, you stop, it's out of your system within 2 days. And again, no long-term effects. But you have to be a little bit more careful with ivermectin if you want to push the higher doses.
I did hear, I think it was on Joe Rogan, there was a doctor on there, I forgot his name now. Anyway, he said that someone got benefit from prostate cancer with just 12 milligrams of ivermectin a day for several weeks. Is that biochemically feasible, or do you think that dose is too small to?
No, it is, and I have seen some really impressive responses to a low dose ivermectin as well. So there is a wide range of dosing, and it really does seem to vary from person to person, and it really varies from I would almost say cancer cell type to cancer cell type, because I could have two prostate cancer patients, and one will respond to 12 milligrams of ivermectin, and the other one may not respond to 60 milligrams of ivermectin. And so there's a wide range of dosing. That's where this becomes a little bit tricky, and I think where patients need some guidance in terms of dosing and response, because the cancer cell killing is dose dependent.
These are things we need to learn, of course. This is not established pharmacology, is it?
Absolutely. I think this is where we need those human trials. We need researchers to be supported in this kind of work. And regardless of the fact that there's no money to be made at the end of this, right? That there's no money to be made for some pharmaceutical company or shareholders of a pharmaceutical company, this is for patient benefit. Absolutely. And this is where where a physician or a scientist is doing something for a patient's benefit rather than for financial interests or corporate interests. And we need support of this kind of research. I think repurposed drugs, there's so much research that so much good research that needs to be done. And so with this dosing of ivermectin, there's a wide range of effectiveness. And I have seen effectiveness as low as 12 milligrams. I can tell you, if you're combining it with chemotherapy, you can get away with lower doses of ivermectin.
Interesting.
And you will see a dramatic response. And the way most of my patients are not telling their oncologists that they're taking ivermectin. And I always, I'm of the opinion you want to be honest with your doctor. You should be honest with your doctor.
Of course.
But if your doctor doesn't have your best interests at heart, then you run into this complicated situation. So a lot of patients are not telling their doctor, and the situation
means the data's not being collected, really.
That's true.
If this is working, the oncologists are going to be thinking they're a lot cleverer than they actually are.
Exactly. And so what happens is the oncologist then has a genuinely shocked reaction when they see an outcome of their chemotherapy regimen that they're not used to seeing. And I've seen this even with radiation oncologists, where tumors are shrinking after 2 or 3 radiation treatments, and the radiation oncologist is shocked. They're like, wow, you had an amazing response to just a couple of radiation treatments, because they're not used to seeing that kind of response. They have no idea that there's synergy going on with ivermectin, where the ivermectin sensitized the tumor, and that's why the radiation is shrinking the tumors dramatically, but the radiation oncologist doesn't know that, and the patient is too scared to tell them, because most of the time when my patients have told their oncologist that they're taking ivermectin or Membendazol or Membendazol, the oncologist has a very bad reaction, to the point, and this happens in the UK, this happens in Canada, this happens in Australia, to a lesser degree in the United States, the oncologist will actually threaten the patient that if they do something like this, that they'll drop them as a patient, which to me is very unethical. But this is
that's bully boy behavior to me.
Bullying. It's bullying, exactly. Yeah. But this is what patients face. And I'll have patients tell me, I made a mistake. I shouldn't have told my oncologist. I wanted to be honest. I wanted to be open. And now they've threatened me. They said, we'll kick you out of the trial. We'll stop treating you. This doesn't happen as much in the United States. I find in the United States that culture, it's not as, the bullying behavior is not there. The oncologists are more open. I've had oncologists say, that's perfectly fine. You can take ivermectin with this regimen, no problem. But once you go outside of the United States, especially in countries like Canada, UK, Australia, there's a lot more of this bullying behavior. And
the idea that a doctor should threaten their patient is just unconscionable.
It's unethical. It's unprofessional. It shouldn't happen, but unfortunately, it does.
It does, yeah.
And so patients have learned that it's better not to tell their oncologist, and their oncologist doesn't even want to know. So when they have a good response, my patients will tell me, my oncologist didn't ask any questions, didn't ask if I was eating different, if I was doing anything different, didn't want to know, didn't care.
We have a name for this in England. It actually comes from Australia, but it's called curiosity deficit disorder. And it's quite a debilitating condition.
Absolutely. And especially in oncology, it's to not have curiosity, to not want
this is what science and medicine's all about. Exactly. Why has that happened? Oh, what's going on there? It's...
Because imagine, as an oncologist, I mean, you could publish it as an interesting case report, or maybe even a case series.
Yeah.
Why not ask the questions? There was a situation, a couple of case reports that have been published with CBD oil, cannabidiol, where patients, there's a couple of 80-year-old patients, they had lung cancer and they refused chemotherapy. They said, "Look, I'm 80 years old. I don't want chemotherapy." And the oncologist said, "Okay, well, we're going to continue monitoring you anyways." And then suddenly the lung cancer is shrinking, and it's gone a few months later. And of course, now these oncologists actually ask the question. They're like, "Okay, what are you doing? We're not treating you. Why is your cancer gone?" And the patient tells them, "Well, I've just been taking CBD oil, a few drops a day, under the tongue for the last few months." And they went and they published those case reports. That is what oncologists should be doing. They should be inquisitive. They should be asking the question. They should be willing to learn. And there's this just absolute absence of willingness to learn.
Obtuse.
Yeah.
So Membendazol and Membendazol both end in azole. So they're in the same group. Do they have similar doses?
They do. So it's a family of antiparasitics called benzimidazoles. Mm-hmm. Two of them are FDA approved, and that's Membendazol and Albendazole. And so you will find Albendazole is also available, and some doctors are willing to even prescribe Membendazole and Albendazole. And then Membendazole is sort of almost like the stepchild, or the it's not FDA approved, and yet it's in the same family with very similar, almost identical mechanisms.
Almost identical molecule,
of action. And so, incredible family, extensively researched, and there are a number of, I would say, about a dozen clinical trials ongoing right now with Membendazole in cancer, looking at pediatric cancers, looking at adult cancers. And so this is not fringe medicine. This is not fringe science. This is something that's being seriously looked at.
There's nothing published yet that I'm aware of, though.
In terms of Membendazole, you're right. I think there's some phase two trials ongoing. So it's, you're right. But, it is being looked at seriously, at least Membendazole.
That's encouraging.
And so that is great. Now, Membendazole gets attacked because it's a medicine commonly used. It's a dog medicine. It's as they call it, a dog dewormer, and yet it's got an excellent safety profile, just like Membendazole. I can tell you, having advised over 1,000 patients on the use of Ivermectin, Membendazole, and Membendazole, there's this myth that the Membendazole and Membendazole are difficult on the liver, that they can damage the liver, and so on. They can raise the liver function tests, liver enzymes, and it's quite rare. It's very rare. I just don't see it.
But if it did happen and you stopped the drugs or reduced them, the liver's got remarkable powers of regeneration, hasn't it? So.
Well, absolutely. So if you do get elevated liver function tests, and I see it in less than 3% of patients, right. I see elevated liver function tests. You stop it for a few weeks, and those liver function tests, if it was the Membendazole or Membendazole, they go right back down to normal. This has been published in peer-reviewed literature as well, that there's this sort of transient, you could almost call it an irritation of the liver in a sense, where you get this sort of transient spike in liver enzymes. You stop it for a few weeks and it comes right back down.
And then you can start again.
Exactly. And again, excellent safety profile established, and really just, I've seen some incredible responses. And I combine the ivermectin with either a Membendazole or Membendazole. I do a combination.
There does seem to be a synergistic effect there, doesn't there? But look, can we look at the doses first of all? So I've been treating worms with Membendazole for probably about 40 years, 100 milligram tablets. So what sort of doses of Membendazole and Membendazole might you be using for various types of cancers?
A typical dose I suggest is 1,000 milligrams a day, split in 2 doses.
And that's the same whether it's Membendazole or Fenbendazole.
Exactly. So either 1,000 of Membendazole and the Stanford case series that you had talked about on another program, they had done 1,000 milligrams of Fenbendazole. I believe it was 3 days on, 4 days off, and achieved remarkable success, achieved remission from stage 4 cancer.
3 days on, 4 days off.
Yes, so that was what the group of patients were doing at Stanford. I tend to use 6 days on, 1 day off, a little bit more aggressive dosing, and same thing with Membendazole, 1,000 milligrams, 6 day on, 1 day off.
1 day. Is that just to give the liver a bit of a break?
Exactly. You give the liver a bit of a break, and again, incredible results. Now you could go less. You could go either 500 of Fenbendazole and 500 of Membendazole if you're dealing with a low-grade cancer, maybe a very early-stage situation. I have a lot of patients coming to me with early-stage prostate cancer. Maybe they don't want the surgery and radiation therapy, and they are looking for a way that they can maybe shrink the tumor or get rid of it altogether without having an intervention and the risks of those interventions. So you could do lower doses like 500 milligrams of Membendazole.
For how long?
Again, I design my protocols for 3 months, and I've done this with Ivermectin and Fenbendazole and Membendazole, and it's roughly the same idea. Is you can start to see changes in cancer markers in about a month. It takes about 2 to 3 months to start seeing shrinkage of lesions, and typically oncology patients, especially when you're dealing with active disease, chemotherapy, immunotherapy, they will have follow-up imaging every 3 months or so, and so you will automatically have that imaging from your oncologist. If not, I encourage patients to make sure that they have imaging follow-up from their oncologist. And so you can see after 3 months or after 6 months if there's been a response to the lesions. And so I had a situation recently with a breast cancer patient who had her surgery was delayed for whatever reason, and she had several months of wait time to her surgery. She had a 7-centimeter breast tumor. By the time, so she was taking Ivermectin and Membendazole. By the time her surgery came around, and there were some enlarged lymph nodes as well. By the time her surgery came around, the tumor was less than 3 centimeters, and there were no positive lymph nodes, where they were certain that there were going to be positive lymph nodes based on the imaging appearance. So she had shrunk her tumor by more than half and managed to eliminate some of those lymph nodes entirely by the time she had her surgery, and this was a matter of maybe 3 months.
It's amazing. So in things like breast cancer and prostate cancer, the traditional treatments will involve hormonal modification.
Yes.
So for example, testosterone blocking for prostate cancer. What sort of interactions, if any, are possible there with say, Fenbendazole and testosterone blockers?
There's no documented interactions that I'm aware of. And it's interesting when you look at drug-drug interactions with whether it's Ivermectin, whether it's Membendazole, there's not a lot of drugs that they interact with in a negative way. And so, for example, for Ivermectin, you have to be aware that Ivermectin does interact with warfarin, and so you have to be aware of that. It doesn't seem to interact with any of the other anticoagulants. And then there's certain antipsychotic medications, I believe, that also interact with Ivermectin. So, there's a few drug interactions to be aware of.
Warfarin's pretty uncommon these days. We tend to use the more modern generations of anticoagulants.
Exactly. So it really hasn't come up as an issue, the drug interaction. So there doesn't seem to be any interaction with any of the hormone therapies, whether it's for breast cancer, whether it's for prostate cancer. You are getting that. You're getting that benefit of the other mechanisms.
Yes.
Anti-cancer mechanisms from the Ivermectin or the Membendazole, that you're not going to get that from chemo, you're not going to get that from immunotherapy, you're not going to get that from hormone therapy.
Yeah. Is Membendazole or Fenbendazole preferable for treating human cancers, or are they much of a muchness?
They are, when it comes to preclinical research, they are very, very similar, especially at higher doses. Yeah. Membendazole is preferred. Now, Membendazole has better penetration through the blood-brain barrier than Fenbendazole, so it would be the preferred agent for any kind of brain tumors.
Central nervous system. Yeah.
Exactly, or brain metastases. And there are certain cancers in which there is more preclinical research for mebendazole, and this would be the squamous cell carcinomas, breast cancers, sarcomas. I'm just trying to think.
It's interesting that you're getting really quite specific there, particular drug for a particular pathology. So knowledge is accumulating rapidly in this area.
That's right, and I do still lean heavily on peer-reviewed research, even if it is preclinical research. If there is preclinical research, I do want to lean on that. And I can give you one example actually for ovarian cancer, for example. Ovarian cancer, I prefer mebendazole over fenbendazole, and why is that? Well, there's researchers in South Korea who've discovered that when they researched fenbendazole for ovarian cancer, there's excellent response in vitro studies, but it doesn't translate to in vivo studies when they were looking at mice. The effect didn't translate to the same degree, and so they've been experimenting, putting fenbendazole into various kinds of nanoparticles as delivery mechanisms, so they could deliver the fenbendazole to the tumor in a much more efficient way. And there's been 3 studies that have come out looking at various delivery mechanisms, various types of sort of nanoparticles. Formulations with fenbendazole. And so
the solubility is fairly low, isn't it? That's probably why you need the higher doses.
Exactly. And so I'm aware of that research. I'm aware that there's been struggle with fenbendazole, getting that drug to the ovarian cancer cells or to ovarian tumors. And yet, when you look at the mebendazole research in ovarian cancer, there is evidence that, it is quite effective in halting proliferation and so on. So I do lean on existing research to decide whether I'm going to use or suggest mebendazole versus fenbendazole.
Interesting. How optimistic are you that as we know more, we'll be able to give, for example, ivermectin and fenbendazole together, enjoying the synergistic effect and being able to lower the dose?
I think in a way, I would say the cat is out of the bag in the sense that this information is getting out.
Yeah.
And it's getting out on platforms like X. It's getting out on platforms, it's getting out on through Substacks. There's other authors, writing about using ivermectin, fenbendazole, or combinations thereof. And so once information gets out and you no longer have this suppression, because I would say the oncologists in a way are suppressed in that oncologists who did pursue non-conventional treatments historically have been targeted. Their licenses have been targeted. Their reputations have been targeted. They often had to flee the country. We have a doctor in Canada who was using repurposed drugs, Dr. Khan, who had to flee Canada after years of battling with the College of Physicians and Surgeons, and now he's in Florida and he's got a clinic in Florida. He had to leave the country. And other doctors look at that and say, well, why would I risk my career and the well-being of my family to pursue repurposed drugs? I'm just going to stick with the guidelines that I get from the American Cancer Society or Canadian Cancer Society, and I'll be fine, right? And so the culture has been very unfavorable towards repurposed drugs or unconventional treatments, but that's changing, and I think it's just the sheer amount of information that is getting out right now. I think it's going to change medicine, and I do believe that with the new administration in the United States, with RFK Jr. Being confirmed and bringing in people based on merit. And bringing freedom back to science and medicine, I think we're going to have a whole new era in medicine where, I think we will have research into repurposed drugs, and I think it will become part of the mainstream. I think it will become a part of mainstream medicine and mainstream cancer treatments.
Just a pity that a lot of people are going to die in pain before we get to that point, which is quite tragic. How important do you think it is to be vitamin D replete when you're getting these repurposed drug treatments?
Vitamin D is very crucial, and I have found that it was crucial for COVID-19. I think there was a lot of evidence that most of the patients who did very poorly with COVID-19 infection, who had severe infections, ended up in the ICU or died, were vitamin D deficient. And I think that's been borne out by many studies. And, you know, it seems to be the case in cancer as well. Vitamin D seems to be protective for cancer. So having high enough levels of vitamin D seems to be protective for you developing certain types of cancers. But I think also as a cancer patient, it's important for you to have high levels of vitamin D. And so I always ask my patients, well, have you had your vitamin D levels checked? And they always say no. And they always say, my oncologist hasn't even brought it up. My oncologist hasn't tested me for vitamin D.
I find that bemusing. I just can't explain. Why wouldn't you test for an important immunomodulator?
And it's such an easy test. It's not that it's a highly specialized test or an expensive test. No. It's a simple test, and I think it's crucial. And so I suggest, you know, high doses of vitamin D supplementation, at least 10,000 units a day.
If someone's low, for sure, yeah.
Exactly, and to have their levels checked. And I said, look, if your oncologist is not willing to do it, get your family doctor to check your vitamin D levels. But very, very important for the immune system.
Well, it wouldn't work in the UK because GPs have been told not to test for vitamin D unless someone's got rickets.
Wow.
Which again is quite inexplicable.